Hello and welcome to this presentation about anxiety disorders. I'm Amy Manley. Today we'll discuss how to recognise and diagnose anxiety disorders as well as consider the underlying neurobiology. We'll discuss 5 disorders: specific phobia, generalised anxiety disorder, panic disorder, social anxiety disorder and obsessive compulsive disorder. Everyone gets anxious from time to time, but what makes anxiety a disorder? Well, there are a few features that these disorders share. The symptoms persist over several months, usually at least 6. They occur consistently when exposed to the feared stimulus or are there most days. The anxiety results in attempts to avoid whatever triggers it or to neutralise the anxiety in some way, and it leads to significant distress or significant functional impairment in the person's personal, social or occupational life. What's more, anxiety disorders are common, with some of the highest prevalence estimates suggesting they affect up to 1/3 of people at some point in their lifetime. When we look at point prevalence in the UK, generalised anxiety disorder shows the highest prevalence at around 6%. Most anxiety disorders affect females more than males with a 2-to-1 ratio, while OCD and social phobia affect females and males equally. Let's look now at how we might diagnose some of these anxiety disorders. Starting with specific phobia. Specific phobia is an excessive fear to a specific stimulus, for example, a fear of spiders. This fear occurs consistently whenever an individual is exposed to the feared stimulus, so every time they see a spider. The feared stimulus may be one or more objects or situations. Fears of animals, flying, heights, close spaces, and the sight of blood can all be specific phobias. The fear needs to be out of proportion to the actual danger, so a fear reaction whenever you, as a zookeeper, find yourself with a lion in its enclosure is not a specific phobia. However, a fear of your neighbour's cat would be. Such phobias lead to avoidance and anticipatory anxiety, so you might find yourself staying inside when the cat is out and becoming anxious when you want to leave the house even before you go out. As with other anxiety disorders, the symptoms persist for at least several months, usually at least 6, and result in impaired ability to function. Let's move on to panic disorder. To describe panic disorder, we must first know what a panic attack is. A panic attack is the experience of intense fear and is associated with physical symptoms of fear, such as increased heart rate, sweating, trembling, shortness of breath, chest pain, and dizziness, as well as anxious cognitions or thoughts. For example, that you are about to die. So a pretty unpleasant experience. Unfortunately for people with panic disorder, such panic attacks occur recurrently, unexpectedly, and are not restricted to particular stimuli or situations, leading to distress and impaired ability to function. Some people become worried about the attacks happening and try to avoid them by avoiding situations they associate with them or by engaging in other behaviours which they think will make them less likely. Moving on now to social anxiety disorder. Many people experience fear when asked to speak in public, and shyness is a normal trait, again leading to anxiety about social interaction. However, when that fear becomes excessive, distressing, and means that the person can't function in their day-to-day life, the individual may well be experiencing social anxiety disorder. This is excessive fear which occurs every time a person finds themselves in a particular social situation, whether that's interacting socially with others, giving a presentation, or doing something where you feel you are being observed, such as eating or drinking. People worry they will embarrass themselves or offend others, for example by blushing or wetting themselves, and they therefore avoid those situations or seek ways to endure them with intense fear. For example, around 10% of people with social anxiety disorder develop difficulties with alcohol dependence. As for generalised anxiety disorder, when under stress, it's normal to feel anxious and to show heightened alertness. In fact, for short times, this can be helpful, driving you to attend to solve the problem, causing the worry, such as motivating you to revise for your exams. However, in generalised anxiety disorder, the worry is excessive and pertains to several aspects of your life. Or it may be free-floating, so a marked apprehension not restricted to anything in particular. As a result, people can feel on edge all the time, struggle to concentrate, can't sleep or can feel irritable, and can experience physical tension, restlessness, and symptoms of sympathetic overdrive, such as a racing heart. And as you can probably guess, these symptoms persist for months and can affect an individual's functioning. As for obsessive compulsive disorder, this is not always classed as an anxiety disorder, but it is very closely related to them. Obsessive compulsive disorder, or OCD, is characterised by the presence and persistence of recurrent obsessions or compulsions, which most commonly occur together. These take up at least an hour a day, affecting functioning. So what are obsessions and compulsions? Obsessions are repetitive thoughts, images, or impulses which are unwanted and cause the individual anxiety. For example, experiencing an impulse to harm someone you care about, seeing intrusive images of death, or thinking that your hands are contaminated or that something bad will happen unless you complete a particular ritual. Compulsions, on the other hand, are repetitive behaviours or mental acts which are completed to neutralise the anxiety generated by the obsessions or to achieve a sense of relief. For example, washing your hands repeatedly, checking recurrently, performing an action a certain number of times, or counting or repeating words or phrases in your head. These may have little direct relationship with the obsession or simply be excessive. Most people with OCD recognise their obsessions and compulsions as senseless. However, a few are fixed in the belief that the feared thing will actually happen unless they complete the compulsion. Let's move on now to think about the neurobiology of fear and anxiety. You've probably all heard of the fight or flight response, which results from sympathetic nervous system activation and is intended to keep you safe from predators by running away or attacking. And you can see how some of the feelings when you experience the sympathetic nervous system being activated overlap with some of those seen in anxiety disorder. The fear when faced with the animal you are afraid of in specific phobia, for example, or the experience of a panic attack, or the constant feelings of being on edge in generalised anxiety. But coming face to face with an actual predator nowadays is pretty unusual. So why does this system get activated? And what's happening in the brain to take us from seeing something scary to having such a reaction and then back to a relaxed state? Finally, how does this explain worry where you're not even actually facing a feared object at all? First of all, let's have a look at some of the brain areas thought to be involved in fear. A lot of the important structures involved in fear processing are evolutionary very old, having been used by mammals for thousands of years. These include the amygdala, vital to generating a fear response, the thalamus, which receives sensory inputs, the hippocampus, where your memories sit, and the hypothalamus, which activates the HPA axis, as well as areas of the brainstem, which initiates sympathetic activation and fight or flight response. Our ability to evaluate and plan a response to a feared stimulus are in the newer parts of the brain, being found in the frontal lobe. And these take longer to get going. All this means that the deep brain structures have been working hard to keep animals safe from predators for years. However, the basic responses generated are often unhelpful to us as humans as we face very different threats. For example, emptying your bladder, sweating and running away will not go down well when the microphone is handed to you for what is supposed to be your hilarious best man's speech. So why do we even find this kind of harmless stuff scary? Take clowns, for example. As a kid, you were desperate to have a clown at your birthday party, making balloon animals and squirting people in the face with water. But then you watch the horror film It, and clowns move from fun-loving, benevolent beings to the stuff of nightmares. So what's happening here? Essentially, you are learning and pairing the object, the clown, with an aversive experience, being terrified, thus making you afraid of the neutral object, even in different contexts, such as the children's birthday party. This is called conditioning. Most of the stuff which generates anxiety does so because we've learnt that it's scary, rather than because it poses a real threat to us. What's more, the more frequently we experience the aversive state and the object together, the more afraid we become. Unfortunately, over time, our anxious reaction to the object can itself become an aversive experience, which in turn reinforces the fear. So should you see a clown panic and run away, this will reinforce the fear, as you'll think, lucky I ran away or I would have come to harm, reinforcing the connection between clowns and danger. But what's actually happening in the brain? Well, sticking with the clown example, firstly you see the clown and hear his laughter, and these visual and auditory signals are sent from your eyes and ears to the thalamus, before being forwarded to the amygdala as well as the cerebral cortex. The amygdala is activated before any conscious processing can take place, acting as your brain's fire alarm and sending signals to the hypothalamus and the brainstem to generate an immediate response. The locus coeruleus in the brainstem bursts with noradrenergic activity, sending the sympathetic nervous system into action, increasing heart rate, diverting blood to skeletal muscle, and dilating your pupils, whilst other brainstem areas trigger your fearful facial expression and an increase in your respiratory rate. As for the hypothalamus, that triggers the endocrine stress reaction, secreting corticotrophin-releasing hormone, CRH, which tells the pituitary to secrete adrenocorticotrophic hormone, ACTH, which in turn tells the adrenal glands to release cortisol and noradrenaline. This is the hypothalamic pituitary adrenal HPA axis, often referred to as the stress axis. Although slower than the sympathetic nervous system to get going, it may be more important in chronic stress, with cortisol being called the human stress hormone and leading to a number of physiological changes intended to promote short-term survival, but which can be unhelpful long-term, including increasing blood pressure, stimulating the liver to convert glycogen stores into glucose, inhibiting ovulation, and suppressing immune function. As you can imagine, such changes increase your risk of hypertension, diabetes, cardiovascular disease, impair your fertility, and leave you open to infection. So with all these fear reactions going into overdrive, what's going to stop this reaction? Well, there are, of course, negative feedback loops in these pathways, and at some point, noradrenaline stores will diminish. But importantly, we also have our frontal cortex, and particularly the ventromedial prefrontal cortex, to evaluate the stressor, recognise it's not so bad, and calm the amygdala down. In fact, it's the balance between the excitatory glutamatergic neurons from the thalamus and the somatosensory cortex, and the calming inhibitory effect of the GABAergic neurons from the ventromedial prefrontal cortex, which keeps the amygdala in a happy balance. Glutamate being an important excitatory neurotransmitter, and GABA being an inhibitory neurotransmitter. So what's the role of the hippocampus in all of this? Well, it's the seat of your memories. This offers input to whether you have encountered such experiences in the past. What happened when you saw a clown last time? But it can also cause stimulation of the amygdala, even in the absence of any external feared stimulus, when you recall a frightening memory. So even this can trigger off a stress reaction. But what about worry? With worry, you're not reacting to something happening now, or even to a traumatic memory. Instead, worry involves recurrent thoughts about a potentially threatening future event. For example, what if I don't pass my exams? Worry is theorized to involve a number of brain circuits, including the cortical thalamic striatal loop, which is actually a number of circuits. These loops involve the thalamus, the striatum, which has a role in predicting the outcome of future situations, with uncertainty stimulating hypervigilance, as well as behavior and behavioral inhibition. The direct pathway also includes the orbitofrontal cortex, which has a role in evaluating reward and punishment and in aversion to risk, with lesions increasing risk-taking behaviour. Thus, increased activity in this pathway may reduce risk-taking, heighten feelings of anxiety, and increase worry. On the other hand, the indirect pathway involves the thalamus, striatum, and the dorsolateral prefrontal cortex, which is involved in cognitive flexibility, the ability to adapt behaviours in response to different rules or conditions, as well as in behavioural inhibition and working memory. Increased activity in the indirect pathway is hypothesized to inhibit worry. However, there is mixed evidence around the role of these areas in worry, with different findings noted in different anxiety disorders, leading to a lack of consensus in what are the most important brain areas and circuits in worry. Nonetheless, some have hypothesized that anxiety disorders may all result from changes in the fear and worry pathways of different intensity and duration, resulting in different symptoms and a shared genetic susceptibility. So how does all of this fit with the treatments we use? Treatment may involve therapy, particularly cognitive behavioural therapy, which talks about how our feelings, thoughts and sensations all affect one another and teaches us to challenge some of the anxious thoughts we hold, such as I'm dying when you have a panic attack. It also involves behavioural tasks such as exposure to the feared stimulus and sitting with the anxiety until it subsides, to extinguish that connection between the feared stimulus and harm, essentially reversing the fear conditioning which we previously discussed. As for medications, we tend to use serotonergic medications such as SSRIs, as this is one of the neurotransmitters that modulates the fear and worry pathways. Other drugs such as benzodiazepines and pregabalin, which increase GABA transmission, which you will recall is the inhibitory neurotransmitter, result in anxiolytic effects, though tolerance and addiction limit the use of benzodiazepines. To summarise, anxiety disorders involve excessive, persistent fear or worry, which results in distress and impaired ability to function in important areas of life. Anxiety disorders are related to changes in important neural circuits involved in fear and worry, which include the limbic system, particularly the amygdala, and the frontal cortex, and the brainstem and hypothalamus, which trigger physical symptoms of fear via the sympathetic nervous system and HPA axis. Treatments for anxiety disorders include serotonergic medication and cognitive behavioural therapy. If you would like to find out more about anxiety disorders, you can check out Psychiatry PRN, which is available via the University of Bristol Library online. You can look up the diagnostic criteria within the ICD-11, which is also freely available online, or you can check out this paper on the neurobiology of anxiety. Thanks very much for watching.
Created using Powtoon.